Today's episode is brought to you by MRO. MRO is the single source for smarter data. Driving a new era of clinical data intelligence, we connect structure and transform data into actionable insights that enable confident decisions, sharpen operations, accelerate research, and elevate patient care. With 24 years of trusted solutions and partnerships, MRO empowers a stronger healthcare ecosystem built on smarter data so teams can measure, learn, and improve. Learn more at www.mrocorp.com.
Hi, everybody. Welcome to Primo Perspectives. I'm Kristen Borth.
Hi, and I'm Lorie Mills. So Kristen, tell me, you sent me an article you wanted me to read about this Trump's great healthcare plan. So tell me all about it.
Yeah, so I just wanted to talk because I think you have really great insights into healthcare and drug costs and utilization of those things. And I tend to come from the opposite side where my family never took me to the doctor and never got me any prescriptions when I seemed to need them. Now, that sounds dramatic. We got them when it was absolutely necessary, but sometimes I felt like it was absolutely necessary. My parents didn't. But all of that to say is that the great healthcare plan has been proposed, and there's some content out from the White House. And I thought this would be a fascinating discussion to dive into, because not only does it touch on, insurance premiums and holding the insurance companies accountable, but it also adds in two aspects that we've kind of already seen other administrations bring in. So, price transparency is one of them, and we've already kind of talked about that before, but we'll dive a little bit deeper, I hope. And then, lowering drug costs, which the Biden administration did slightly do for a few, or maybe more dramatically than I even know. So what are your thoughts on the drug price decrease?
So that would be fantastic for me. And as you know, so Kristen knows, I have a lot of medication I have to take every month because I am a type 1 diabetic. I have thyroid disease and other things. And so I do take quite a bit of medication. And I will tell you this. So about 4 years ago, I was getting a vial of insulin at a 340B pharmacy for $2.89. So it was costing me like $4 for a 2-month supply of insulin. Now, even though it's still very, very low cost for me, now I'm paying $70 for the same amount of insulin that I was paying $2.89 for.
Wait, that went backwards. I thought that it was supposed to be cheaper.
Yeah. So that is kind of where, in today's world, some of our medications are going up. Yeah, and insulin may be a bad example because there's like a $35 cap on a bottle of insulin now. And Trump passed that in the first one, his first term. But some medications are just getting really outrageously ridiculous. My dad takes Eliquis. It's $700 and something if he gets it through a regular retail pharmacy, but I can get it through 340B for a lot cheaper. And so, we've got to figure out, how do we lower these costs of these medications? Because it's really putting a strain on not only our seniors, but just people in general. I talk about it all the time and hear about it in some social media groups I'm in, people having to ration their insulin because they can't afford their insulin, or their insurance copays are so high. So, and I feel so guilty when I change out my pump and I throw away like 10 units of insulin. And I feel guilty about that because medication has gotten so expensive and it's just become an issue all the way around.
What do you think that would do for our patients in healthcare if we did get a cap on drug costs? And it was, $2. So for $4 for what you were getting, and I'm assuming that's per month.
That was for a month.
$70. That's huge. That's a big. That digs into so many things. So what do you think, just as a whole? And I know we're guessing here, but just our professional educational guess of what we were thinking. What would you think that would do for our patients in general?
So in general, those costs are going to make it much harder for patients to get medication. Therefore, it's going to lead to more exacerbations of chronic conditions. We're going to see more people in the hospital. In the South, you're from Arkansas. In the South, we have a huge population of congestive heart failure, diabetes, things like that. A lot of smokers down here in the South, and just not having access to medication is going to increase the number of admissions we have and the care that needs to be given to these patients.
Yeah, that's what I was thinking. I was thinking we would see higher numbers of resources utilized in the hospital, higher admission rates, whether it be at the ED or to inpatient, because they can't sustain. And then on top of that, taking it outside of healthcare and just looking at economy in general, they have less money to spend on their groceries, so healthy food and things like that. They have less resources that they're going to pay for to be able to maybe get healthy or find support. So lowering drug costs as a whole seems like it would be really positive, but wow, it seems like it would have just such a big ripple effect of positivity if we did cap and lower those costs, especially with those really common drugs. And I know you brought up, insulin, but that is a very common drug that people are utilizing. You would think that, and maybe this is just me, you would think though that they would lower those costs because so many people are on them that it would be impacting a large number of people.
But that's just it. There's so much money, and I am not against capitalism. Let me tell you, I'm all about industry making money. But when you take something that is necessary to live, I mean, for type 1 diabetic, insulin is necessary to live. I would die without it. Then we do have to look at what do we need to do. And insulin, this is what just kind of blows me away about insulin. The founder that created insulin, he gave the patent away when it was created because he knew it was a life-saving drug. So he gave it away, or it was like minimal that he sold it for. And so, and insulin's been around for 100 years. So now we're thinking we've got a medication that's been around for 100 years. Why is it so expensive? For people. Other drugs, there's another drug. So I take Manjaro as well. And before anybody says, well, you're not supposed to take that, you're not a type 2 diabetic, there's some reasons why I can take it. But it can be as high as $1,200 a month.
What?
For a month's supply. So when you're looking at that and you're thinking, so, okay, I make, say you bring home $1,000 a month. I mean, $1,000 a week, which most people don't bring that amount home, especially in the South.
Yes.
And then you've got a medication that costs $1,200.
Oh yeah. You're not paying for a lot of things.
Right.
When you have that expense.
Yeah. And, love Trump, dislike Trump, whatever. I think his what he's wanting to do is great and admirable. And we really do need to look at how do we make that happen? So I hear a lot of small hometown private-owned pharmacies are closing, and it's all going to the big boys. And the reason for that, a lot of times, is called a PBM. And I can't remember what PBM stands for, but it's like a middleman from the pharmaceutical company to the pharmacy. This middleman, and they're the reason, according to everything I've read, that the prices are so expensive on a lot of our medications.
Yeah, the pharmacy manager, like, person who's in the middle, like you're talking about, it's ridiculous what they're doing, because they spike those drug costs up, and that doesn't go to the actual, pharmacy. That goes to the patient. And so it's just really amazing. I mean, it does go to the pharmacy too. That's why they're closing. But ultimately, the impact is for patients, because that's their livelihood in a lot of ways.
That's right. That's right.
Yeah.
And so I do want to throw out, just for people that may not know, so there is a drug program in the United States. It's called a 340B pharmacy. And those pharmacies can sell medications at a much lesser cost than retail pharmacies can. There are some stipulations about which doctors you have to use and referrals and things like that. But if you are struggling paying for your medication, you need to check on if there's a 340B pharmacy in your vicinity, because it really does help cut cost. The $700 Eliquis I was telling you about, I can get a 3-month supply for my dad for like, I think I pay, it was $25.
Yeah.
So, and patients just don't always know that those resources are out there.
Yeah. I was really shocked to find out about GoodRx and how much cheaper of a discount that I would get not having a 340B, around me at the time. GoodRx helped a lot too. And so I was really impressed by that and glad to see that. But ultimately, to me, there's a big portion of this that comes back to the insurance companies and the pharmaceutical companies, just in general.
I think we all kind of wind up there a lot of times, back to the insurance company. I just had a conversation this morning with a practitioner here at the site I'm on, and I kind of got tickled, and because he asked me, he's like, how often are you here? And I said, I'm here once a week. He said, all day? I said, yeah. I said, he said, it just takes a lot to fix the problems that we have. And I started laughing. So then he started in about insurance companies and, how the hoops they have to jump through. And I told him, I said, I understand. And I think sometimes we forget how difficult it is, not only as a patient with insurance companies, but our providers as well.
Yeah. So with the Great Health Plan, and I agree with your provider, but with the Great Health Plan, they're looking at making insurance companies accountable. And that is something I would have never put in one sentence. No. That, the federal government, or even just in general, anyone is trying to make health insurance companies accountable. I mean, we harped on those a few episodes ago where it was like looking at how much, they made. But just in general, it is ridiculous, not only for a citizen to get insurance, but also when you look at doing corporate insurance and what that does. I mean, there is never a time that I have been working in, the corporate world that my health insurance has actually gone down. Right. And this is not good or bad against any administration. Just the reality of what I saw is when I was doing having insurance for my family, Obamacare came in or ACA came in, and it was shocking to me how much my insurance went up. And I'm like, wasn't it supposed to go down because so many more people were going to be insured? So we were all going to be quote unquote cost sharing.
Yep.
And yet it didn't go down. And so I have so many questions about how you're going to hold them accountable.
I agree. I think that, I've wanted to report payers to the insurance commissioner in our state before. It's just crazy, some of the things that happens and what we have to go through. And I think accountability is really good, but not only for insurance companies. I will say this too: everybody has to be accountable. Providers have to be accountable, patients have to be accountable, and insurance carriers have to be accountable. And so I think it's we got to fix all of it. Just fixing one part of it's not going to work. And which brings up another topic on this: the big healthcare plan is we were talking before the show started about, getting subsidies, or you getting the money to pay for your premiums and all. So what do you think about that?
Yeah. Well, the idea is really great. I think the idea is really great. The actual application, I'm not so sure that it's actually going to happen. I mean, I do like the idea of getting a little extra and putting that in my HSA account. I use my HSA account for a lot of things that my insurance company is like, I'm not going to pay for you to go to the chiropractor. And I'm like, well, the chiropractor makes me feel better than going to a doctor once a year. So I'm going to go to the chiropractor, and I pull that out of my HSA or whatever they don't pay. I use that. So I love that idea for me. But then I can't help but wonder how many people are going to be like, oh, I'm getting refunded or reimbursed for certain things. I'm just going to go use this money for something else that I would prefer to do.
Yep.
So I don't know. What are your thoughts?
So I feel like the majority of people would probably put that money aside, like you said, in a HSA or something,
Yeah.
and use it appropriately. I do.
Yeah.
But as always, there is part of the population that is not going to do that. And so then what happens are we get the money, we spend it, and then we get sick and we have to go to the hospital. Well, guess who's still left holding the bag? The provider. It's it's typically the provider, because it is amazing the number of patients that do not pay their bills at the hospital, because there's so many different reasons why, but they just don't pay. So the provider winds up having to write that off, and it's a loss to that provider most of the time.
Yep. Yeah. I mean, there's a challenge there when you get a check and it's pretty big and it's actually for a bill, and you're over here looking at that, those shoes that you wanted to buy or a purse, like I would do. I'd be like, oh, look at that purse. It's hard to say no to something that feels indulgent when you have bills that you need to pay, but they don't make you feel as good when you pay them.
No.
Maybe they should send you a cupcake or something to make you feel really excited to pay it or something. I don't know. Yeah. Bills are never fun to pay.
No, they're never fun to pay. Never. Yes, I would much rather go shopping or something like that. But just for instance, so Monday, I had been on a 2-week work trip and came back on Monday and was sick. And so I knew I needed fluids. So I called a nurse practitioner that has a feel good clinic where they do different IVs and things like that. And so I went over and had 2 liters of fluids run in, and it was $300 for getting 2 liters of fluid. And I can file it on my insurance, and I probably will. But the thing is, it's expensive to be sick, and get sick is expensive. And I think a lot of younger people, they don't think about that. I know they don't think about that. My 20-year-old doesn't think about getting sick or having a problem. And so I feel like most of them would probably spend that money instead of using it the way it needed to be used.
Yeah, it's true. We don't think about it, and I remember I was 22 when I started randomly fainting, and I had not thought about it prior to that. And then even after, my doctor telling me, well, we don't know what's wrong with you, we're going to have to do some more tests, I really didn't think about it. And cycling through multiple doctors and then getting those bills finally, it takes a while sometimes. And then getting those bills and being like, oh, this is painful.
Yeah, it is.
You don't think about it until you have to. And so I would hope that we would be planning for the future. And I do think that a lot of people plan for the future with, their 401k or their savings or whatever they're doing, their investments of whatever kind. But, being able to invest some money that you are getting refunded back for healthcare is really fascinating to consider if we actually would do that. Like, would that be the go-to, or would it be the go-to to put that into savings where you could then, potentially use that?
So maybe a thought is that everyone has an HSA set up by the federal government, and instead of getting the check, the money goes into the HSA, and then you have to submit your receipts and all for your reimbursement, or submit to have your insurance premium paid out of the HSA. That might be more feasible than actually sending people just a check. Here's $2,000, to pay your insurance premiums. Oh man, I'm like you. Those shoes I saw, they're calling my name, and I just need those shoes. So why do I want to pay my insurance premium?
Exactly. Well, and I've heard a lot of people say that, well, I don't really use insurance. I don't really need insurance. And so they might take the money, and then, push comes to shove, something happens, and accidents do happen where you do need healthcare. And those things can rack up quick. When it's an accident that you're, trying to work through. especially if it's more of a longer recovery time.
Mm-hmm.
And so I don't know. I have
Yeah.
so many thoughts about what I would do, and it makes me excited because I'm like,
Yeah.
oh my word, I would be really, gearing up my HSA. That would be fantastic. And, helping with things like orthodontic work or whatever we need for the
Right.
kids. But then at the same time, I don't know. I don't know how the nation as a whole, unless maybe there was really good education, you
Yeah.
know.
Yeah, even good education, I don't think is going to, the population that would spend the money is going to spend the money. I
That's
mean,
true.
it
That's true.
doesn't matter how much you educate; they're just going to do it.
Yep.
Yeah. So I don't know. There's a lot of questions about how it all would work.
Yeah.
I would love that, but I'm going to be responsible and pay my premiums and all with
Yeah.
it. So, who knows?
Yep.
I'm like you though. There'll be a lot of tweaking done to it before anything is final, and it probably won't even look like the original when it gets
Yes.
done.
I agree. But that is one of the things where, I've said this now so many times over the last few months. But that's to me one of the things that could be a part of that great reckoning that we are looking for coming down the healthcare industry. Whereas like, we've got to correct the ship somehow. We've got to start working to move it. And maybe that's part of it. Maybe that's the support or part of the direction that we need. And so it starts off and it's bumpy and it's rocky because it's not perfect, but then it moves into all right, here's your HSA account through, the federal government, and you get your card, because I get my card through my, I think it's called basic HSA, and they put the money directly in there. I never see it. It's pulled directly from my check. So it makes it very easy for me to start moving it over and not think about it. Whereas you send me a check, and I'm not irresponsible with my money, but you send me a check, there's that tinge of, ooh, I saw those shoes, or there was that purse I've really been wanting, and or more likely that vacation that I've really been wanting to go on. I'm going to go on that vacation now.
Right. Yeah, and I think as a whole, that would be a lot of what would happen when we get to that point. Yeah.
Yeah.
So what do you think about, we've talked about the price transparency a little bit before, but what do you think about the whole price transparency thing? I've got my opinion on it, but what's your opinion?
I think it's something that's been tried. I don't think that we've been really successful with it. I'm not saying that it won't be successful. I think that's the one that I am most skeptical about, because we've tried price transparency. It's there. You can go and find out prices for all kinds of things, but I don't know that that is directly lowered or impacted any type of healthcare pricing. What about you?
I don't know. I don't think it's worked the way they thought it would.
Yeah.
The whole thing about the price transparency is that your patient, they know what their cost is going to be when they leave the hospital. Well, the federal government has said, okay, yes, well, you give this estimate to the patient, but the hospital has to take into account, so what is the anesthesiologist going to charge? What's the radiologist going to charge? Groups that are not even affiliated with the hospital, they've got to try to, project what they're going to charge and all, and put all of that on the estimate. That's not working because we are not affiliated. Each group is not affiliated, so you don't know what they're going to charge. I think a lot of the younger people may go on and look at price transparency, but the older people typically are not. We don't necessarily go on and look at who's got 5 stars, who's got 2 stars, on the star rating scale. So we don't necessarily utilize that. And so I think it's costing facilities more money to make price transparency happen than it's actually that it's worth. So I think that, and it's like all things, people talk about how expensive healthcare is. There's a lot of things that providers do that's not even related to patient care that we have to do that cost a lot of money, but we have to do it. Cybersecurity for one, trying to just make sure everything is protected, and our EHRs, how they're very expensive, and that is added cost to providers that does not have any return on investment a lot of times.
Yeah. Yeah, I do find that to be really uh the really broken part of price transparency is that they can guess all day long, and they do have, you know, for the ones that they have contracts with, sure, they have contracts with them and they know an idea of this, but they don't have a very good picture of what is the price is going to be based on the care that is needed or the care that is provided. And so that's the hard part. I know they state on the White House page for the Great Health Plan that they want it posted. So if a Medicare or Medicaid facility, is utilizing Medicaid and Medicare funds, then they need to post their prices in their place of business. So I know this is so basic, but all I could think of was, oh, so like a coffee shop where I'll know what I'm going to get if I want a 12 ounce, a 16 ounce, or a 24 ounce cup of coffee, and they're going to put it out there. But then you start adding all these different things. So I add milk and a different type of milk. And I'd actually like this creamer along with this creamer. And sometimes those coffee orders get big, and you can have a $15 cup of coffee because you've added and changed and, multiplied and doubled and tripled and, all those things. And so that's what, to me, on a very small, very, very little scale, this idea of price transparency makes me think of. It's like, okay, so yeah, their prices are there, and someone could walk in and say, oh yeah, I just need, a basic care. But that basic care might turn out to be far more expensive because they wanted, the top shelf, not just the basic care once they got in there.
Yeah, that would be something I would do, would be the top shelf.
Yeah.
Just because I'm just extra, as my children tell me. You're extra.
Me too.
But yeah, when you go in and you start picking and choosing, you want this and you want that, and know, and we were having a conversation before this started with Seth about concierge medicine, and that's becoming a big thing now, where people are taking cash and they're not using insurance, and they're going and they're paying cash for things.
Yeah. My husband's uncle actually does basically concierge care for functional medicine, and I love his model. I think it's absolutely fantastic. It would be left out of any of these, make the healthcare plan great again ideas, but at the same time, I really like his setup, and if I were to find a provider like that, I think I would go with that. I think they pay like $500 a month, and if you had an HSA plan, you could use it to pay for that, and you can see your provider anytime, and it's a 30-minute call.
Yeah, we have a couple of those in Hattiesburg that does concierge care, and it seems to work really well. And sometimes I think that might even be better than the whole rigmarole of, okay, I go and I rack up this $8,000 bill. Well, how much do I really owe of this $8,000 bill? How much is my insurance going to pay? And where I could just go in and plop down $1,000 and just get the same treatment,
Yes. Yeah. Well, and wasn't it back in the day, like doctors were actually paid to keep their patients healthy, and like they were getting payments like monthly, where it was really, the goal was to keep their patients healthy. You only called them when you needed something, and so I would love that model. Like, yeah, give, a component of my premium to my provider if I've not utilized any services that I had, like, that were unexpected, obviously. So if he could work to make me healthier, I would totally pay for that.
Oh yeah, I would too. It would be so much better. And I think though, we have all the wellness benefits that we have on our insurance, and you think, well, everybody utilizes their wellness benefits, right? But they don't.
No.
Because I'm on a lot of calls with our different payers that have quality programs, and they're always saying, "Oh, you got to get these patients in for their annual wellness." And yes, we need to get them in for their annual wellness. But when you call and schedule and they don't show up, and they keep canceling or they won't come, it's like, how do you make them get their annual wellness?
Yep.
You can't go pick them up and bring them to the hospital and get them examined. I mean, you just can't do that.
Right.
But so, I think we've got some foundations in place,
Yeah.
but we don't utilize it. A lot of patients don't utilize it.
Yeah.
And sadly, many of the patients that don't utilize it are the ones that need it the most. There are
Agreed.
chronically ill patients. And you don't know if that's because their health literacy is just lower and they don't understand, or if they, do have transportation issues. Why can't they get into the clinic to get their wellness visit?
Yeah. Yeah. Well, and that's the thing, we can harp on it all day long, but it's really up to the patients themselves. And that's kind of, I don't know, that's aside from holding the health insurance companies accountable and lowering the drug costs, I kind of think that that's kind of the nail in the coffin for a lot of healthcare activities. There are so many things we need to fix, but we can't control our patients. We can advise them, we can tell them what to do, but until they decide to actually change, or they decide that they're going to make the changes or follow the guidance or whatever of our providers, we're kind of at the mercy of what our patients are willing and able, not just willing, but willing and able to do. So
right. And yeah, and there's so many things, like I said, in this bill or this proposal that I think would be really good. It's just how do we manage it? How do we make it happen? Because I'm not for government being in my business all the time. I'm really not. And so then you open up, well, okay, so the federal, we have insurance for all, healthcare, universal healthcare, whatever you want to call it, for everyone. And then, so what do? Does the federal government get involved and say, you have to go have this done? You must, or you're going to be fined or taxed or, whatever. So there's a lot of questions there, but I am glad that the conversation has started about doing something with the payers. I think that it definitely needs to start there. But where it's going to end, I don't know.
Yeah. I will say that I'm very thankful. I know that conversations, and I'm remembering mostly though as a teenager and, early college kid, but I know that the Bush administration kind of started some conversations around healthcare. They were very minimal and they didn't really go anywhere. The Obama administration, in my opinion, really took that and tried to do something, and it wasn't perfect. We all know that nothing that comes out the first gate, is ever perfect. It's got to go through a lot of different processes. Yep. And so I love that was started, that was tried. I think it lasted too long. That trial period went too long without any real, in the depths of it, changes happening so that it could actually still make those changes and those movements to being a positive thing. But I also think that, then the Trump administration, the Biden administration, they carried different portions through. And I think we're just really slow to make those changes, unfortunately. Yeah. Whereas we need to be much quicker coming out of the gate.
So have you seen the healthcare industry ever be quick about something?
No.
I mean,
no, never.
In our world, it is so slow. You talk about rapid change, and things change rapidly, but we don't keep up with it because we are so slow to change in the industry. Yeah,
it's true. It's true. As we wrap up, I would like to say I sat on a webinar listening to Amy Gleason talk about what was encouraging and exciting to her. And for those that don't know, Amy Gleason is leading the DOGE efforts with CMS. And she was being interviewed through Verisma, and it was a great webinar. So you should go out and you should look at it if you can. But she talked about that speed, she talked about the excitement with that speed. And I loved that. I was so excited about that because someone's finally mentioning the speed that is needed and the desire that was needed. And not to say that any administration is perfect, but I loved that someone who is in it and seeing what was going on was very excited about seeing the change that was coming down.
Yeah, that's great. You need to forward me that link so I can go and listen to that. That would be great.
I will. It happened yesterday, so it was great, but you should definitely check it out.
Well, we need to post it in our show notes so that anybody else that wants to can get to it.
Absolutely. Well, Lorie, this was fun. Thanks for sharing your insights.
All right, Kristen, I enjoyed it. Thank you very much. I hope you have a great day.
You too.
All right. Bye, guys.
Bye.